funny one because this was basically the same lecture you have in endocrine, if you want, and they shifted it to CVP 531 because it's related to atherogenicidity more than endocrine problems. So it's going to be the same thing. So let's sit, enjoy, review it, because you will see a lot of these questions coming in USMLE about lipoproteinemias. So we'll try and review it and make it as simple as possible. I did simplify it so that at least you would remember it. Objectives. Why it's not clear? It's what? I don't think it's the light.
I think the brightness of the computer.
It's out of focus, actually. Or maybe wanting, I think I need new glasses. It's not focused, right?
Yeah, it's not.
I mean, this is not your first lecture, is it? Was it focused?
No.
You should complain, actually. You should try to get this fixed. Anyway, so let's review lipoproteinemias. And these are the objectives for today's session. And we do expect you to know the clinical importance of the lipoprotein disorders, especially the ones related to or associated with high risk of coronary and peripheral vascular diseases, since this is cardiovascular block. We do need you to look into acute pancreatitis and why hypertriglyceridemia would lead to increased, basically, risk of acute pancreatitis, but also what else happens when you have high triglycerides?
Atherosclerosis.
Is it related to atherosclerosis?
Yes.
It is. And the same thing for non-alcoholic fatty liver disease. So patients with non-alcoholic fatty liver disease, they would have high risk of developing myocardial infarction, heart attacks, and so on. And finally, you need to differentiate between hypercholesterolemia and hypertriglyceridemia, because each one has different therapy. So you need to be able to tell the difference. My role today is basically to teach you the language so that when I say type 2A, type 3, type 5, is this atherogenic, non-atherogenic? This is my rule, is that for you to learn the language, I cannot list the number of lipid disorders. There's so many, but you're going to see them in almost in all the questions in USMLE, textbook, and so on. So at least you understand the language. Which apolipoprotein will be increased in this condition or that. This is what I'm going to try and do for today's session. Now, if you look into lipoproteins, this is really bad. You have it in your system, right?
Yeah.
Yeah, but you need to fix the projector. If you look into the lipoproteins, we have shown you this several times in terms of the structure of lipoproteins. It's composed of either lipids or proteins. The lipid component will be the core of the lipoproteins, and this is triglycerides and cholesterol ester, and this is the core of the lipoproteins. Now, if you look into the outside, so this is hydrophobic, the outside is more kind of hydrophilic. You'll find the apolipoproteins or apoprotein, and you can see there are multiple ones in the lipoproteins. And you see the phospholipids bilayer and the cholesterol spanning from the outside phospholipid bilayer to the core that's containing triglyceride and cholesterol ester. What is the function of apoprotein or apolipoproteins? 3 functions we said last year. It has what? Binding to the receptor. That's one. Activates the enzyme, lipoprotein lipase, alcat. Thirdly, structural integrity of the lipoprotein. These are the three main functions of the apoproteins. Now, when we say high density versus low density, what do we mean by that? Where does this nomenclature come from? High, low, intermediate. The name comes from the fact when you spin the plasma, I take plasma from patients, spin it at high speed, I get layers. Based on the density of these particles, chylomicrons, VLDL, or chylomicron remnants, leftovers after it delivers its package, the triglyceride, then you have the LDL and HDL. You can see that the density, you can see the diameter here is increasing, but the density also is decreasing. This is inverse. This is what happens is that the HDL will come at the bottom. On the top will be the chylomicron, the large, don't sink after you spin that sample. This is where the name comes from. Now, what do you think is with the chylomicrons? It's loaded with what? We need to know. Why? Because when we say we're going to differentiate between hypercholesterolemia and hypertriglyceridemia, if you know what is increased in the patient profile, you should be able to tell what's the difference. Because when you look into that, oh, this patient has high triglyceride. So most likely it is what? It's got some chylomicron. It's got some more of the VLDL type. So that's when you get the triglyceride. Now I want you to know, when you read patient lipid profile, two things you get. Triglyceride total. Total meaning that all the triglycerides in all of these you'll get as one value. Ideally, you want it less than 250 milligram per deciliter. And cholesterol. In all of them, this is total cholesterol. But usually we get HDL. What did we measure in HDL? It's telling us it has other apoproteins, it has cholesterol, it has other things. Cholesterol ester. We're talking about HDL dash cholesterol, so cholesterol content in HDL. When we say LDL, LDL dash cholesterol, so cholesterol content in LDL. We want the cholesterol to be in the HDL, not in the LDL. And we'll talk about this. So as a physician, reading the profile, lipid profile, total triglycerides, or total triacylglycerol. You want to call them trig, same. Total cholesterol, and then you go for LDL cholesterol, HDL cholesterol. Okay? This is how you can tell whether you have hypertriglyceridemia, whether you have hypercholesterolemia as well. Now, this is the same slide I used last year. Again, this lecture now is being taught in CVP rather than endocrine in case you just walked in. We have chylomicrons which transport the dietary triacylglycerol, triglycerides. This is in the, where does it happen? Chylomicrons are synthesized, which tissue, which organ? Enterocytes, in the intestine. How much of your diet is triglyceride? 95%. So most of your diet, 90 to 95% is triglycerides. And that gets taken into chylomicrons. We have VLDL. VLDL is synthesized by which organ? The liver. Okay, and it's loaded with what? Triglycerides. But what happens? Chylomicrons in from the gut. Through the lymphatic system, now it has to dump it into the circulation. So the liver takes it, and what happens? I mean, the chylomicrons, if you're fasting, it's not in your plasma. If you're fasting. If you're not fasting, you just eat. Why do you think your blood, if I spin it after a meal, it becomes turbid? Is it VLDL, LDL? Chylomicrons. Chylomicron gives it that lipid-like solution. Okay? So it becomes lipemic. So when you see someone, when we order a lipid profile for a patient, we always ask for a fasting blood sample. And if you see it that it is lipemic, two cases here. Either he's cheating, he just had a meal, or he has genetic condition associated with hyperchylomicronemia. And how do we know that? Make sure he's fasting, and let the sample, blood sample, sit. I'm talking about the plasma. For 24 hours, you'll see a layer of chylomicrons basically forming at the top of the plasma. It's called standing test. Standing blood test, okay? So, this is VLDL. We have the intermediate density lipoproteins, which are a product of LDL processing of VLDL and chylomicrons. We have the LDLs. These are the most cholesterol-rich of all lipoproteins. This is why we always say it's the bad cholesterol. It's in the LDL. Why? Because it's delivering cholesterol to the tissue, peripheral tissue. Whereas HDL, on the other hand, reverse transport, takes it from the tissue back to the liver. What happens in the liver? Secreted as bile. Here's my question. Can you change the cholesterol level of a patient by changing his diet?
Remember you asked us that question and we said no.
No, you said yes, and I said no. Right? Well, as I said, this is a review session for you because you have the lecture. It's nice because you're going to see it in terms of atherosclerosis, in terms of hopefully getting closer to your USMLE, at least you understand the language. Most of the time, you cannot change it with the diet, cholesterol. And what happens? The fact that you cannot change it with the diet, because even if you take diet with low cholesterol, it's not going to change because most of the cholesterol is synthesized in your body. Most of it. We said around 90% is synthesized in the body. So the diet is not going to make that much difference. I'm not saying that advise not to, don't change your diet. You do have to change your diet, but don't expect that much for cholesterol. Yes?
Doesn't the diet change LDL to HDL cholesterol?
Well, the cholesterol, when you deal with it, you're dealing with the absorption. In the diet, it has maximum capacity. Do you see what I'm saying? So, you're taking too much cholesterol doesn't mean you're gonna absorb more cholesterol. Slightly. So, it's all about the absorptivity more than the diet itself. Okay, and then we have the lipoprotein A, and there's a lot of talk about lipoprotein A, and we said it is atherogenic. And you'll see towards the end we have a slide for the lipoprotein A, and I'll tell you why it is considered as atherogenic, as it competes basically with plasminogen, which is responsible for fibrolysis, right? To break the clot. So we'll talk about it at the end. We have a slide about this. Okay, every time I show a table, which it's sad actually, it's bad. Hopefully, again, you have it in your... What if I dim the intensity here? Would it work?
It might work.
Doesn't look like it can dim it here. I don't see any peak. Well, you can see it on your laptop. Now, every time I show a slide that's heavy like this, you ask me, what do we need to know? And the answer, a couple of things. I summarize for you the apolipoprotein that you need to know, and I'll tell you why. Because there are conditions associated with mutations of these apolipoproteins, and what's the effect in the lipid profile. So, to look into lipoproteins, we have chylomicron, remnants, VLDL. I cannot see it. HDL, see the mouse please?
Yes,
HDL, don't worry about the subtypes for HDL. Chylomicrons, we said, in the intestine. And they're loaded with what? Triglyceride. Right? So the main lipid component you need to know for each lipoprotein. We have the VLDL. They're also loaded with triglycerides. LDL, cholesterol, HDL, cholesterol, and phospholipid to some extent. At least know the main lipids in each lipoprotein. That you need to know. If you look into the apolipoproteins, the one that I want you to know is the apolipoprotein B100. If you look into it, where is it present? The 100. VLDL, IDL, actually the E is in the VLDL. So I don't know why it came down. The LDL. You can see that it's VLDL all the way to LDL. So it has the ApoB100. What if I use an antibody to precipitate the LDL and the LDL? What do I end up with? Chylomicrons or HDL, but chylomicrons is not present in a fasting sample. So I end up with HDL. So it's the same cholesterol test to measure the total cholesterol, or I can precipitate the VLDL, LDL by an antibody against the APO100. What's left? HDL, and I can measure the cholesterol. The same method, but it's in the cholesterol, in the HDL fraction. Also, if you remember in MOL, we had the RNA editing, and we talked about the B48, basically, which is shortened version of the apolipoprotein B100. It's in the intestine. This is in the liver, the ApoB100 synthesized in the liver. So the B48 is present where? Chylomicrons, chylomicron remnants. Anywhere else? No. Now, what about the A1 and A2? These are the alpha lipoproteins. These are present in the chylomicrons, A1, A2, to a lesser extent than the HDL. So we know that this is not present in the plasma when we take the lipid profile. So A1, A2, HDL, and these are basically the major apolipoproteins of HDL. They're called alpha lipoproteins, designated A, and it is made in the liver and intestine. So we need to know the A1 and A2, and we'll know why. When we start discussing some diseases, you'll see that I'll say that there's a mutation in this APO100, or there's a mutation in the A1, A2, and so on. The ApoE, it's a ligand for binding to LDL receptor. So where do you expect to find the E? HDL, IDL, VLDL, chylomicrons, and so on. It's a ligand to bind the LDL receptor. So what happens if there's a mutation in the ApoE? If there's a mutation in ApoE, what happens? What is going to increase? Is it going to increase in terms of the chylomicrons? I'm talking about circulation in general. Well, everything is going to be decreased. So ApoE is ligand to LDL receptor, so there's no binding to the LDL receptor. So this is similar to familial hypercholesterolemia, which we said it's 1 in every 500, right? So you're going to have high levels of VLDL, of chylomicrons, everything. And finally, the ApoC2, which activates LPL. So LPL, lipoprotein lipase, where is it present? Which tissue?
Fat tissues.
In the endothelium, in the lining of the endothelial cells, in the vessels. That's where you find the lipoprotein lipase. We have hepatic lipase and we have lipoprotein lipase. So lipoprotein lipase is the one, if you recall, with the pathway here. Well, it's in the endothelium lining of your vessels. So what happens? It takes the triglyceride, it hydrolyzes triglyceride into fatty acids and glycerol. So if LPL here is blocked, why? Because the ApoC2 is mutated. And we know it's needed to activate the LPL. Whether here or whether here, what happens? There's going to be increase in VLDL. And that is loaded with triglycerides. Right? So at least you need to differentiate between hypertriglyceridemia and hypercholesterolemia. So you need to know, this is why I ask you to know these. We're going to discuss mutations to these apolipoproteins and what happens with the lipid profile. This you've seen before several times. We have the absorptive pathway, chylomicrons are formed, rich in triglycerides. Then we have the liver, which secretes the VLDL, also high in triglycerides. Lipoprotein lipase, in the endogenous pathway, basically will convert it to LDL. LDL gets delivered to the cells where they utilize the triglycerides, cholesterol, for energy, for whatever synthesis happening in the cell. Now the LDL, also the triglyceride, could transfer the lipids or cholesterol to HDL. And this is done by an enzyme called CETP. Stands for cholesterol ester transport protein or transfer protein. You have the LCAT, lecithin cholesterol acetyltransferase. Now, if you look at the cell, you can see that the LCAT basically transfers the cholesterol from the cell to the HDL. This is called reverse cholesterol transport pathway. You've seen these slides, you know it. Just review it and get it over out of your system for this lecture. These are giveaway review sessions with questions. You should be familiar with it right now. So we're trying to make you to love biochemistry, which never happened. It's funny, my daughter was studying medicine in the US and she had biochemistry and she said, Dad, I don't want to say this, but I hate biochemistry. I said, no need, I hate it too as well. But anyway, so let's look into this pathway. You can see here that we have the peripheral tissues and we have the HDL lipoproteins. Notice here we have ApoA1. If you recall, I asked you to know the ApoA1. And what does it do? It binds to the HDL receptor. We have the HDL receptor, and actually it was listed here. Did I talk about this? No, not yet. Actually, we're going to talk about it. It's HDL receptor right there. So it's by ApoA1. What happens when there's mutation in ApoA1? What do you think the HDL is going to happen to HDL? Increase or decrease? It's going to decrease because when you say HDL, You're saying cholesterol in HDL. And cholesterol is not reverse transported to the back from the peripheral tissues. So the HDL will go down. And there are conditions where they're associated with ApoA1 mutations. Now, HDL has what? Cholesterol. And what happens? That cholesterol gets transported where? To the VLDL remnant and chylomicrons remnants, and then into the liver. CETP, what's its function? So the ALCAT is activated by ApoA1. So its function is to transport cholesterol from the tissue. We asked this question and many students complain about it. Cholesterol to the HDL. What about the CETP? Transport the cholesterol from the HDL to the VLDL and chylomicron remnants. So, what happens if you block CETP?
There's HDL.
You think HDL is going to increase or decrease?
Increase.
It's going to increase, right?
Yeah.
And as a matter of fact, there are 2 drugs now being developed and under investigation to block CETP as HDL that will cause HDL increase. What are the 2 methods that you could increase HDL? Can you increase HDL by medication?
Yes.
Well, they're investigating the CETP inhibitors. What else? Exercise and alcohol. Red wine, not even white wine. This is because of resveratrol. I talked to you about it. Resveratrol as anti-aging. I'm not advocating for drinking, but what I'm saying is that even people who drink alcohol, eventually, this will affect the liver, and as a matter of fact, VLDL and LDL will increase because this will affect the absorption of VLDL, so it's going to fight back. So it's not beneficial as they say. But this is one of the reasons they say that if you notice that there are many advocates, especially in the Western community, that a glass of wine will help you prevent atherosclerosis, but eventually, if you look into it, it will cause liver damage and will increase VLDL. It becomes atherogenic at the end. At the same time, why not, if you want to see if you could increase HDL, let's take resveratrol, which is right now available as supplements, and it is from red grapes. Would it increase HDL? I haven't seen any solid data showing that it will increase and protect from atherosclerosis. Another third thing, estrogen. Estrogen would increase HDL. Okay, this is why premenopause versus postmenopause. Premenopause, we have estrogen, so the women are less likely to have heart attack or stroke, whereas after the menopause, you'll see that their risk would increase drastically because of the fact that estrogen would induce HDL. So, for the enzymes that are important in lipid metabolism, we talked about lipoprotein lipase, and we said it's produced by the endothelial cells, and it is activated by ApoC2, which is present in the chylomicrons and VLDL. So what happens when there is a mutation in ApoC2? Lipoprotein lipase activity what? Goes down. As a result, we have VLDL, chylomicrons. So what happens? Triglyceride or cholesterol is going to increase. Triglyceride. So if there's a mutation in the ApoC2. Liver lipase, which is activated by interaction with the ApoE, and then the LCAP and CETP. Receptor-wise, we have lipoprotein receptor. Another name for it, ApoB100, ApoE receptor. Why do you tell us the other name? Because some textbook will use either LDL receptor or the ApoB100, ApoE receptor. And we talked about the ApoE. What's its function? ApoE binds to the LDL, activates binding to LDL. So we talk about the function of the LDL basically, and when there's increased intake of cholesterol, people taking too much cholesterol, this would downregulate the LDL receptor in the liver. As a result, there's decreased uptake of LDL from blood. So it will increase in circulation. HDL receptor localized predominantly in cells that synthesize steroid. Why? What is the precursor for steroid synthesis? Cholesterol. So it's taken from the HDL. Okay? Scavenger receptor, is it a good thing or bad thing? Let's see if you still remember last year's lecture. Good thing or scavenger receptor? Looks good or bad?
Bad.
Bad. Especially when it's in the monocytes. You remember it causes atherosclerosis. Why? Because it takes LDL or oxidized. Where do you get the oxidation of LDL? When there is free radicals, when there's oxidative stress. Right? And this is a troublemaker, scavenger receptor, especially with atherosclerosis. I did a study, published it, where we gave actually 300 calories of lipids. I have these pictures of coffee cream. Coffee creamer. 300 calories. Of course, we did glucose, 300 calories, protein, 300 calories, 300 calories of coffee creamer. And we sampled from these volunteers who were medical students, 1 hour, 2 hours, 0, 1 hour, 2 hours. And we stained the lipids in these cells before and after the coffee creamer. You should see the droplets. I mean, you feel like the coffee creamer is inside these cells, monocytes. And you would say, well, why is it taken there? My belief is that monocytes are responsible for the majority of conditions, diseases that we have in our bodies. Why? Because they're responsible for inflammation. Inflammation is basically being attributed to every condition you could imagine. Inflammation, inflammation, inflammation. Where do I get inflammation? I told you, when you eat, you get that subclinical kind of inflammation level. So if you keep hammering yourself by eating too much, eventually this will lead to oxidative stress, will lead to inflammatory response, and eventually will lead to atherosclerosis and so on. And this is a fact. I mean, we did Big Mac muffin. It was really huge inflammatory response. We did orange juice, 300 calories. We did diets rich in fruit and fibers, didn't induce that much. So you are what you eat, believe it or not. It's true. Meaning that your white blood cells, even if you look into right now, into the peripheral fatty tissue, you look at it, they're loaded with macrophages, inflamed macrophages. And this is published by so many research groups. So the macrophages, every condition, you'll see that there's monocyte that's causing the problem. So you need to, what's the best way is to take small amount of food. Small calories, number of calories at different times. So this way your body can override that inflammatory response. Anyway, we'll talk about it when we talk about atherosclerosis. Now, I'm going to be just listing the types of disturbances that you will see with lipid metabolism. And that is, when I say essential, primary, I'm referring to what? Primary. When I say primary, it's usually what? Genetics. Secondary are the conditions. So when we say primary or essential, so usually it is genetics. We have hyperlipoproteinemias, hypo, and dyslipidemia. You have this slide, so understand, you've seen the slide. I'm going to make it simpler, because I have many questions about what do we need to know about this slide. So I'll make it simple for you. This is the Fredrickson classification of hyperlipoproteinemias. There's so many available. This is the most commonly used one. So why are we using it? Because if you look into the textbook, you're going to see someone saying type 2A, type 3, type 4, type 5. What is meant by that? Well, the Fredrickson classification of hyperlipoproteinemia classifies the phenotype of hyperlipoproteinemia into 6 classifications. 1, 2A, 2B, 3, 4, and 5. Phenotype. And we'll see the language. I'm here to teach you the language. I cannot list for you all the conditions associated with hyperlipoproteinemia. But at least when someone says, oh, it's associated with type 2A, so you know what do we mean by type 2A. So if you look into which lipoprotein that is elevated in each phenotype, type 1 is chylomicrons. Type 2A is LDL. 2B, LDL and VLDL. Look into 5, chylomicrons and VLDL. So if I tell you, that's all what you need to know. If I say type 1, chylomicrons, which one you would expect to be high? Triglyceride to be high. Why chylomicrons? Type 1. What about the HDL? Cholesterol. It's going to be low. What about the LDL cholesterol? Low. There is a problem where there is increased chylomicron, triglycerides high. Right? Is it atherogenic? Well, the only 3 types that are associated with coronary atherosclerosis or peripheral atherosclerosis includes type 2A, 2B, and 3. That you need to know. 2A, 2B, and 3. Why? Because you're going to say this type is atherogenic. This type is non-atherogenic. So when you say type 2A, 2B, 3, you would say, oh, this is an atherogenic phenotype. How do I know what is what? Look into what is the component here mostly elevated? LDL, right? LDL is loaded with what? Cholesterol. So LDL cholesterol is high. What about 2B? LDL and VLDL. Cholesterol. Cholesterol is high. 3, chylomicrons and VLDL. Well, cholesterol is normal. Slightly low. But why is it atherogenic? HDL, normal. Cholesterol, low. What do you think? ApoE. The molecular defects here is ApoE. So, the LDL receptor is affected, right? Familial hypercholesterolemia. So that's what I want you to know. As I said, just know which one is increased. Based on that, you can easily tell what's increased in terms of triglyceride, in terms of HDL, cholesterol. Which one are atherogenic? Well, we said 2A, 2B, 3. What about pancreatitis? And why are you telling us about acute pancreatitis? Because this acute pancreatitis, basically what happens? They're associated with hypertriglycerides. You can see it right there. Okay? And what about the xanthomas? Notice here the xanthomas, especially the 2A, which is atherogenic. We have the tendon and tuberous xanthomas. And we'll show you pictures of it. It is with 2A. So we're going to start listing these conditions of hyperlipoproteinemias, and let's see if we can understand the language. As I said, I'm here to teach you the language. So let's take the first example. We have the familial combined hyperlipoproteinemias. And if you notice here, I made it in bold, genetic. This is the most frequent genetic hyperlipoproteinemias. This manifests itself as phenotype 2A, 2B, and 5. What does this mean? So you'll see which phenotype, 2A, LDL, 2B, chylomicrons and VLDL. And we said this is basically accompanied with metabolic syndrome. Strong risk factor for the development of atherosclerosis and ischemic heart disease. Why? 2A, 2B. Next one, familiar hypercholesterolemia. Right away, you should know it. It's LDL receptor, right? So it manifests predominantly by phenotype 2A, familiar hypercholesterolemia. And we said the LDL receptor is mutated. 1 in 500. As a matter of fact, you get myocardial infarction in the 4th decade of life. Around age 40. Many people, they have a heart attack, they die, and it's like, he's only in the 40s. Most likely he has it. He doesn't know that he has it. Mechanism involved here, we have mutations of LDL receptor mutation, decreased uptake of LDL, increased concentration of LDL in blood. I remember I told you the story of my manager, it was John Love. He had familial hypercholesterolemia. He used to run 10 miles a day. He was so athletic. His LDL cholesterol was around 2,000 milligram per deciliter. What's the normal? This time, 130. So his parents had 4,000 and 5,000. It was amazing. Yet he was active, exercise. He would exercise every day, 10 miles a day, and still won't go down. Polygenic hypercholesterolemia, from the name. Polygenic, meaning multiple causes. Poly. So there could be environmental factors, alcohol, diabetes, increased intake of carbohydrate and lipids, but there is also genetic predisposition. This is the most frequent hypercholesterolemia compared to most frequent genetic hyperlipoproteinemia. Now, the 4th type, familiar dyslipoproteinemia. Familiar dyslipoproteinemias. Manifests in type 3. So, type 3, we said type 2A, 2B, 3, that's atherogenic. So, type 3, that's atherogenic as well. Oops. Familial hypertriglyceridemia. And this basically manifests in type 4, hyperlipoproteinemia, overproduction of the VLDL from the liver. That's an inherited disease. Finally, the last two, familiar defect of LPL and ApoC2. What did we say about ApoC2? It activates lipoprotein lipase. So if there's a mutation in LPL or in the activator, you end up with familial defect of LPL and ApoC2. Okay? And this will lead to what? Accumulation of triacylglycerides, so hypertriglyceridemia. And there is hepatosplenomegaly, high risk of acute pancreatitis because of the fact that they have high triglycerides. Okay? Then you have the familial hyper-alpha lipoproteinemias. Alpha, as we said, this is in the HDL. Remember A1, A2? So when there is increase of hyper-alpha lipoproteins, there's increased concentration of HDL. This is basically genetics. There's decreased risk of atherosclerosis, and this could result from low dose of alcohol, genetic disorder, or estrogen.
But if you have high concentration of HDL, what is considered a disease?
It's not a disease. It's. I mean, people are lucky. I wish I could have it. I mean, my HDL is, believe me. The pool, the gym is only like 10 meters away from my villa, and I don't even exercise there. It's just we don't exercise. As long as you don't exercise, your HDL is going to be low, LDL is going to be high. Okay, secondary. Induced by other chronic diseases, and this is a list of them. Hypothyroidism, nephrotic syndrome, chronic renal failure, primary biliary cirrhosis, chronic alcoholism. Also some drugs such as contraceptives, which could lead to hyperlipoproteinemias, especially increased LDL. Here's a table you've seen before. Do I need to know it as a physician? Yes, you do need to know it, but I'll make it simple for you. I don't expect you at this time just to know comparison. LDL could be elevated or reduced. Elevated LDL is bad in hypothyroidism, whereas reduced LDL in hyperthyroidism. You can see the difference. Nephrotic syndrome, cholestasis will lead to elevated LDL, reduce in severe liver disease, malabsorption, malnutrition. HDL, elevated alcohol, exercise, exposure to chlorinated hydrocarbons, drugs such as estrogen, reduced smoking, type 2, diabetes, obesity, malnutrition will be associated with reduced HDL. Chylomicrons will be increased in type 2 diabetes. Notice here type 2 diabetes will be associated with chylomicrons increased, with VLDL, reduced HDL, so it's really bad in all cases here. Now, as a doctor, you do need to differentiate between hypercholesterolemia and hypertriglyceridemia, because the treatment is different. Now, what I did, 2 slides where you can see that this is hypercholesterolemia. There's increased LDL cholesterol. The conditions, you've seen it. Familial hypercholesterolemia, you've seen it in the slides before. Familial defective ApoB100. Polygenic hypercholesterolemia. These are all associated with high cholesterol levels. How do you treat high cholesterol levels with? Statins, right? Even though I told you before that some studies came now, let's use this, statins, because there was no change in the prognosis. So do we prescribe or we don't prescribe? We still, right now, if I say 1/3 of your patients will be on statins, so would you prescribe it? Still debatable, but even though most people do use it. Now, this is just to show you the xanthomas. We have the tendon xanthoma, and we have the tuberous xanthoma that you'll see with high LDL cholesterol. This slide shows you basically the lipid disorders that are associated with hypertriglyceridemia. And we also had some of these, and you do need to know it. Why? Because the treatment for the hypercholesterolemia is different than hypertriglyceridemia. And these are the conditions associated with it. If you were to go take each one, understand the mechanism, you should be able to differentiate between the two. As I said, I'm here to teach you the language. You should be able to remember, figure this one out by yourself. What about low levels of HDL? We talked about it. We said, in this case, just know that there's a mutation in the ApoA1. Just the ApoA1. Don't worry about the other ones, the locus and so on. The ApoA1, what did we say about it? In the ALCAT? HDL receptor. It activates the ALCAT, right? So if there's a mutation, there's no ALCAT, so there's no cholesterol reverse transport. Tangier disease, where there's ABCR1 deficiency, you'll see it in the next slide when I talk about scavenger receptor. The ALCAT deficiency, we know what the ALCAT, what does it do, right? And then you have the primary hypoalpha lipoproteinemias, inherited causes of high levels of HDL, CETP deficiency. This is why I said now they're targeting CETP drugs so that they can block it, and the familial hyperalpha lipoproteinemias. Lipoprotein A. This is a summary of this slide, basically. You've seen this slide before. All what it is, this is the LDL. This is the LDL. And in the LDL, you see the lipoprotein A. Right there, the green one. Attached by disulfide bonds to the ApoB100. So, this is Kringle. It's called this binding site actually. The Kringle. Yeah, it has five domains basically, and one of it is called the kringle, and it competes with the plasminogen basically. It has similar characteristic as plasminogen. What's the function of plasminogen? Fibrinolysis, right? And it binds to the TPA released by the endothelium, binds to the plasminogen. Plasminogen gets activated to plasmin, and the plasmin would basically digest this thrombus clot. Now, the lipoprotein A would bind to the TPA, right? So plasminogen cannot exert its effect. It has to bind to the TPA. This is why plasminogen activator inhibitor is atherogenic, because it could bind to the TPA, preventing it from activating the plasminogen to plasmin. This is why lipoprotein A is atherogenic. Okay, we said scavenger receptors, you remember? You have these pictures. These were given to me from Russell Ross. These are real pictures from monkeys that were fed high-fat diet. Look into the endothelium lining. These are all endothelial cells. These are from monkeys, arteries, and vessels. Now you start feeding them high-fat diet. Look into the monocytes. They start infiltrating the endothelium. You can see some platelet, and then you can see the infiltration. You can see initial plaque formation, and finally you get this plaque. This is plaque rupture. This is a plaque. You see it? These are accumulated monocytes. These are real images from monkeys. So it's just amazing. Basically, you can see that we have scavenger receptor that would take oxidized LDL, and LDL, it pumps the oxidized LDL into, which is loaded with cholesterol, into the monocyte. Usually this gets pumped out with the APCA1 transporter, but has limited capacity, so cholesterol accumulates and you end up with this foam cell formation. It is for real. These are the normal levels. Do I need to know it? Yes, you're going to be a physician, hopefully, and also your family can ask you, or friends, oh, you're going to medical school, I just got cholesterol level of 250. Is it normal? Is that, it will be embarrassing at least if you don't know, right? So you have the total cholesterol less than 200. People say, well, accept it up to 240. Recommended is 200 milligram per deciliter. This is the total. You look into LDL cholesterol less than 130. HDL more than 40. These are the borderlines, and these are high risk. So you do need to try to get it above the desirable limit. Triglyceride less than 250 milligram. What's the therapeutic benefit of elevating HDL? Protective from atherosclerosis, heart attack, and stroke. This is basically everything we said. And people with above than 50 milligram are protected from atherosclerosis. Alcohol and lipids, we discussed it, and there's nothing else to add. So I talked also about the fact that drinking would impair the ability for liver to take up the LDL by the LDL receptor, resulting in increased LDL in the circulation. So you could debate with someone who's saying drinking is beneficial. Acute pancreatitis and hypertriglyceridemia, we just said it. This is basically the third most common acute pancreatitis etiology after gallstones and alcohol because of hypertriglyceridemia. And finally, we said the non-alcohol fatty liver disease. Usually it will be associated with what? High LDL, and this would make them at high risk of cardiovascular risk, basically in terms of developing atherosclerosis, heart attack, and stroke. So if anyone has non-alcohol fatty liver disease, so you do need to care about their atherosclerotic steps. With that, I conclude. So it wasn't bad after all, right? So at least it's a good review, and you know the kind of questions to expect. Any questions? Thank you.